along with such eminent oncologists here. Kindly allow me to share my screen. And
recording.
My screen is visible, I hope.
Yes, sir.
Yes, sir.
Thank you. Just a second. Right. So the topic given to me is how do we select and sequence therapy in advanced renal cell carcinoma, clear cell variety. And many of you know all these illustrious cricket players, and right from Sachin Tendulkar to some of you may know some of the old names like Garfield Sobers and Don Bradman and Dr. Wakkar Yunis and Steve Waugh. So what is common? They are all featuring in the list of all-time greats in the cricket field in all kinds of cricket. But if suppose all of them are available to you, and imagine that you are all IPL team managers and you have to choose your team, what will you do? Currently, the IPL franchisee managers, go through some ideas. They have some techniques. They look at what is their remaining kitty of money, and then they look at how many slots they have available and whether they can take an Indian player or overseas player and how much they can cap on a highest for a single player. So these are all some of the facts based on which an IPL team is selected by the franchisee manager. Their ultimate goal is to win the cup. And in the context of our RCC, we can say that our ultimate goal is to achieve a progression-free survival and an overall survival. So that's our goal, like this cup. So from that context of survival, if you look at what happened in 2004, there were only 2 FDA-approved drugs in 2004, and the median survival in advanced RCC was around 12 to 15 months, as you all know. So one can call that as a dark age of renal cell carcinoma. As compared to the current times, one can call it as golden age of renal cell carcinoma. Why? Because there are 15 FDA-approved drugs in 2019, and the median survival, that's the most important goal, has reached up to 36 to 48 months in 2020. So that's the change in the paradigm. It all started with the work from Robert Monster's group and published in 2008 and 2009. Sunitinib, as compared to interferon, showed the progression-free survival at 11 months as compared to 5.1 months. That really changed the paradigm of how we treated clear cell metastatic RCC in the first line. Then for about 10 years, it was sunitinib and sometimes pazopanib. They were ruling the roost. And by 2015, we started having the access to axitinib and everolimus. So if patients progress after single agent sunitinib or pazopanib, you would go to axitinib or everolimus. And if the patient further progresses, you would do whatever is left to be treated. That was the sequence that was available, and that was the paradigm. But then by 2017, we started to understand that the treatment can be approached differently. We started to risk stratify these patients as favorable, intermediate, and poor risk. And then we started having the access to nivolumab and the cabozantinib, and in the second line setting. But now, if you see what is available, there are so many good players available. Be it cytokines, and in VEGF TKIs, you now have the cabozantinib, tuvozanib, and lenvatinib. And then if you go to the immunotherapy, you have the Nivo, UP, Pembro, and avelumab. So this number of good players are available to you to choose. The only problem is how do you choose and how do we sequence? There are some ways to select. You all know that you would automatically look at whether the patient has got a good risk profile, indolent disease, or an intermediate or poor risk profile, or a very aggressive disease. You may have to also consider whether the patient was treated with first-line TKI, because that's the very common scenario throughout the country. So these are some of the selection criteria based on which you will choose your treatment when the patient is sitting in front of you. There are some guidelines, of course. We all allude to the NCCN guidelines, and NCCN guidelines would say that in favorable risk, you would choose sunitinib, pazopanib, or pembro axitinib as the preferred regimen. Whereas in poor and intermediate risk today, the choice in 2020 for XCCN would be to have Ipi-Nivo category 1, Axi Pembro category 1, and Cabozantinib as choice. So there are other recommendations, but these are the principal choices as of now. But it would be nice to know how each of these players performed real time on ground and what is their match track record so that we can make realistic, correct choices whenever we choose these patients in front, where the patient is in front of us. For example, if you're thinking about a single agent TKI as the first line, then what is the data? We all know that it has been always sunitinib and nothing else was available. So, is there anything that can perform better than sunitinib? We have tivozanib, we have axitinib, but there was a trial compares as sunitinib versus pasopanib that nothing was different between the PFS and the median overall survival to choose between the two. Tivozanib and axitinib showed some superiority over a single agent previously known VEGF TKI, but it was sorafenib, and also the choice of the patient were all groups. Whereas in a specific intermediate and poor risk group, we have a very good trial. That's the in which the cabozantinib for the first time showed that something superior can be achieved over and above sunitinib. And the median PFS with cabozantinib was 8.2 months as compared to 5.6 months with sunitinib, and 26 months median survival, overall survival as compared to 21 months median overall survival, but that was specific to intermediate and poor risk group. So we have a good player who is doing better than sunitinib in the intermediate and poor risk group. So that's the randomized cabozantinib trial for you, phase 2 trial. The most important point to note also is the overall response rate of 46% that can be achieved with cabozantinib, whereas you would achieve an overall response rate of 18 with sunitinib. There is no real axitinib versus sunitinib, randomized control trial in the first line. That's the answer that we want. But there is something indirect to derive from. There is a real-world multi-center analysis. This is basically from a Japanese group who looked at around 169 patients from 5 to 6 hospitals, and this was over a period of 10 years. And the bottom line is, compared with sunitinib, axitinib had a significantly prolonged, overall survival, a better safety profile, and clinical response rate as compared to sunitinib in the first line. So whether you want to draw something out of this in your clinical practice today, you can think about this, but that's the landscape of their data set. The relative dose intensity that can be delivered with axitinib was good, and the treatment discontinuation with axitinib was lower than sunitinib, and the objective response rates were better PFS and cancer-specific survival, overall survival, and the first-line TKI failure-free survival was all superior with axitinib, but this is a collective Japanese data and in a non-randomized controlled trial setting. Now, what about choosing two agents in the first line? Is it superior to sunitinib? That's the answer we want. For example, is pembro axitinib better than sunitinib single agent, or Ipi-Nivo better, or axitinib avelumab, and then now we have atezolizumab, bevacizumab. These are the doublet combinations that are available today, but what is the data set to draw some information out of this? For that, we need to divide the patients into favorable risk group and look at the data set, and then divide them into poor and intermediate risk group and look at the data set and try to derive our decision making. This is from the favorable risk group. If you look at the pembro axitinib study, that's the keynote 426, and the Ipi-Nivo study, checkmate 2 and 4. So what do we know? What did these doublets achieve in favorable risk group? Unfortunately, for anyone, it's very easy to understand the curves of almost superimposing. And what we know out of this is there is no significant overall survival difference by adding a doublet in the favorable risk group as of today over and above sunitinib. That's the gross message. But then if you look at the PFS, yes, the pembro plus axitinib showed a superior PFS as compared to sunitinib alone. And then we also had a better overall response rate with pembro axitinib as compared to sunitinib. You didn't see this ORR advantage with, mind you, with the Ipi-Nivo. That also something to be noted. So in the favorable risk group, what we now know today is that there is no significant difference in the overall survival with these doublets as we compare to sunitinib. But of course, we can achieve a better PFS with pembrolizumab, better ORR with pembrolizumab. And so whether you want to look at that, it's up to you when you deal with your patient in front of you. What about poor and intermediate risk group? Whether these doublets can score over the single agent, S12 sunitinib. What do we know? Of course, the NCCN has put this as a preferred option in poor and intermediate risk group. Ipi-Nivo is category 1 and pembrolizumab is category 1. You all know that. But then, this is the Nivo EP and the pembrolizumab data set. Both of them had a good follow-up, 23 months and 42 months. So good follow-up. And what was the long-term benefit achieved with these doublets in this intermediate to poor risk subset? You can see that the Ipi-Nivo and also pembrolizumab, both of them tend to show a superior overall survival as compared to sunitinib alone. For example, the Ipi-Nivo would show an overall survival of 47 months as compared to 26 months for sunitinib alone. And the median overall survival with pembrolizumab is not yet reached as compared to sunitinib, which is the same 26-28 months. So something has really changed when you use the doublet in the poor and intermediate risk group. And if you want to draw some comparison with the historical understanding that, in the era of high-dose interleukin-2, we know that there were some patients, which were about less than 10%, who were really long-term survivors, and we were always looking at that flat curve of those IL-2 patients who were the excellent responders. We always knew in the back of our mind that there is a subgroup and IL-2, there is a flattening of the curve and long-term survival. So are we seeing something like that in the long run with these doublet therapies? This is the overall response rate with Nivo EP with 42% and axitinib pembro 55%. That's the overall response rate. And if you want to look at the CR, complete response rate of 10% with Nivo EP and 6.5% with pembro-axitinib. And then one more thing that you need to know is, we all know that one of the problems with the immune checkpoint inhibitors, particularly with MR, metastatic renal cell carcinoma, is that there are something called early progression, and we'll be interested to know what is the progressive disease rate with these doublets. So we have a progressive disease rate which is around 27% with regard to 27% with regard to the Nivo EP, and around 14.6 with the pembrolizumab. But if you look at these curves and try to derive some lessons out of these landmark analysis, what you see is that with the Nivo EP, you see that at around 9 months, the curves are starting to separate. And you see a similar effect with the pembro-axitinib. That's okay. Now then, if you bring it to the next time point of 30 months, what you see is that the Nivo EP is beginning to flatten. This is something that we always want to see, whereas the sunitinib is still going downhill. And then if you look at the pembro-axitinib, you don't see that flattening yet, and the sunitinib is following its previously known diktat of continuous downslide. And at the end of around 42 months or 30 months plus, what you see is that the Nivo EP is really flat, and the sunitinib has come down to really 18 to 19%. And here is where you have the median progression for the sunitinib, both the studies around 8 months, and the Nivo EP has got a median PFS of around 12 months, and the pembro-axitinib has got a median PFS 12.7 months. But please note the flat curve of the Nivo EP. So what is the significance of such CR or some very good responses that can be achieved? Of course, we clearly see the duration of response in these studies. And we note, particularly with the NEO-IP study, that in patients who have achieved a very good response or a CR, there are still 34% of patients who continue to be on treatment, and 47% of the patients are taken off treatment but have not yet received the second line therapy, and only 19% of the patient went on to receive a second line therapy. This is with regard to the NEO-IP, and this is with regard to the people who achieved the CR. So there is something very important. If you achieve a very good response with these studies, and what is the toxicity profile? This is the toxicity profile. At least as compared to sunitinib, the toxicity profile is not bad when you use the doublet, and even over a period of time, you see acceptable toxicity profile. We are all afraid of the toxicity with NEO-IP, but what we were looking at so far is 94% had some adverse event. But what needs to be looked at is that, of course, 60% needed systemic steroids, but 80% of them resolved, and except people with skin rash and endocrine dysfunctions, most of these side effects with the NEO-IP could be managed, or they were able to resolve. So that is something that we need to understand. So the conclusion for the doublet in the intermediate and poor risk is that there is a short-term efficacy. You need to be mindful of the toxicity, and the long-term efficacy. We are now aware of the long-term efficacy of IP-NEO and the pembrolizumab, and here is the avelumab axitinib also, which is a phase 2. That's why I have not put it there. But the overall context of all the three trials of these doublet trials are put here. What we know now is that as of now, the NEO-IP is approved for the high-risk group, whereas the pembrolizumab is approved for both the high-risk and also the intermediate, both the high-risk, intermediate, and the favorable risk group. What about subsequent therapy? I'll be very brief around here. These were the original available in the Robert Morse's 2000 to 2010 era. Axitinib, sorafenib, everolimus were the available agents, and what could we know then? The PFS around 8 to 5% and ORR of anywhere between 10 to 20%. But there are now a lot of new players, so and there are some guidelines. And so, what do we have as the data out of all these players? Let's quickly review. What we now know is this is the post-TKI therapy data set. You are all already aware of the axitinib and everolimus. I have already told you, so we concentrate on the cabozantinib and the nivolumab and a phase 2 data from lenvatinib, everolimus. All the others are phase 3. So the bottom line is you can reach an ORR of around 20% with the cabozantinib or single-agent nivolumab, and you can still reach a median overall survival of 20 months. And on a quick run, axitinib, everolimus, axitinib is better, and cabozantinib, everolimus, cabozantinib is better. These are all in second line. And again, nivolumab, everolimus, nivolumab is better. And so that's the message. Nivolumab post first line therapy can still give you a good overall response rate of 25%. There is another interesting approach wherein patients who are treated with nivolumab single agent, that if they progress, you rescue them with addition of ipilimumab. That's the Titan trial that adopted that strategy, wherein you would give an immunotherapeutic boost with the addition of ipi with the CTLA4 inhibition. So you will see whether you can boost the effect. That's the data set. The boost effect will lead to a higher PFS. And the checkmate 16, in which the ipi-nivo combo in patients who have been prior treated, so in second line setting, the ipi-nivo combo, this is what it can do to you, and this is the putting into context of the role of the doublet ipi-nivo in the patients who are already treated. You can still reach ORR of around 11%, and you can reach CR in the salvage setting of 2.7%. But remember, this is the first line data set of NEO-IP, 39% ORR. That was the original data set. This is the lenvatinib pembrolizumab for people who are interested. I'm not going into the detail. This is the second doublet. in the second line setting. So this is the summary of what we know in the second line setting. If patient had done well more than 1 year with the first line single agent VEGF inhibitor, maybe you can consider a second VEGF inhibitor with cabozantinib or axitinib. And if the patient had a brief response to a single agent VEGF inhibitor, say pazopanib or sunitinib, and then if you want to later on consider a VEGF IVO combo, consider pembrolizumab plus axitinib. And if there is no response to the first line single agent VEGF inhibitor, maybe you should consider ipi-nivo or single agent nivo. And if there was no response at all to VEGF plus IVO, then you have cabozantinib or axitinib. And there is some interesting data evolving with lenvatinib, everolimus. So there are many new players added. So as a good captain, you have to pick and choose so that your eye is on the cup. So you will be able to do that. And our eye is on the survival and the quality of play, so on and so forth. And while Dhoni thanked the nation, we want to thank him and thank you all for listening. Thank you.
Thank you very much, sir, for such a wonderful presentation. It was truly an enlightening one in the beginning. So may I request Dr. Advani, sir, to share his wisdom with the audience. Over to Advani, sir, please. Sir, am I audible?
Yeah, host, I think. Over is host.
Yeah. We'll go to the next actually.
To share my slide presentation. Good evening. Can everybody hear me? Good evening.
Yes, sir.
Mr. Ashutosh Shukla, Dr. Advani, if he's still there, Dr. T. Raja, Ulhas Patra, Dr. Sahu. I can only name a few illustrious people from the oncology community of India, but there are lots and there are many more. But I address all of you this evening and I thank the Adlai Pharmaceutical Company to sort of not stay behind from what needs to be done in changed circumstances of COVID, and therefore a virtual meeting that I'm part of today. The topic that I've been assigned is, there was some issue with Dr. Advani's, but I hope that I don't suffer the same fate. The topic that has been assigned today is surgical metastatectomy for metastatic renal cell cancer. Now, yes. So, just to sort of introduce myself, I live in New Delhi, and surgical metastatectomy for renal cell cancer is almost the same scenario for all solid tumors. And quite often now, surgical oncologists like me are sort of in a corner lots of times, not being able to keep pace with the evolution of newer and newer evidence-based therapies as far as surgery is concerned, when I compare myself to my medical oncologists and what is happening in the medical oncology sector. And therefore, why I'm saying this today is because today also, I'm continuing to fight the same battle and try and save the domain of surgery in advanced cancers, advanced solid tumors. Sometimes you get encouraged when you see results, what Sugar Baker got with peritonectomies, for instance. But there is not enough evidence to build up a case where I can argue absolutely boldly and blatantly with my medical oncology colleagues and convince them. Now, the same scenario, for instance, just to give you an idea of what we're talking about, metastatic renal cell cancer, ladies and gentlemen, about 30% of patients that come to us already have disease at the same time and in the secondary sites. Another 30 to 40% will develop distant metastasis over the next few years. And of all this metastatic renal cancer load, 2/3 that you see are basically multi-site disease, which means there is metastasis not just at one site. We're not talking about one site of what we call as oligometastatic disease. We're talking about multi-site disease. And the commonest sites that you see today is lung, being about 45 to 60%, followed closely by bone at about 30 to 40%. And then, of course, liver and lymph nodes almost the same at about 20 to 30%, adrenals 8 to 10%, and brain 5 to 10%. And there are unusual sites. Unusual sites like pancreas. I'm mentioning pancreas because I have a tale to tell you about pancreatic cancer, metastatic disease. Also thyroid. And all other sites which are not in the thoracic and the abdominal cavity can sometimes have unusual deposits from renal cell cancer. And a statement that all surgical oncologists love to make, that renal cell cancer, ladies and gentlemen, by its nature, by tradition, is generally a chemo and radiotherapy resistant disease. Is it not? Look at all the figures. Isn't that why for the last 80 years we have been trying to use surgery even in metastatic disease, right from 1939, when I think Churchill and Barney sort of reported it the first time in metastatic renal cell cancer? And even today, let me assure you, with all the so-called immunotherapeutic combinations and all the VEGF inhibitors, the so-called targeted therapies, complete responses are rare, aren't they? Or am I wrong? So, in such a scenario, wouldn't surgery continue, in essence, to be present in a situation like this? And of course, as far as the traditional thinking of oncology goes, metastatectomy in solid tumors, there are only 2 randomized, double-blind clinical trials that are reported in the literature so far. The Anderson Cancer Center in Texas, Houston. One was for non-small cell lung cancer, and one was for castrate-resistant prostate cancer soon after, where it was proven by randomized studies that metastatectomy for local control after the systemic therapy added a benefit in more than one situation. So, before I begin my 2 words today, what do the guidelines say, my friends? The commonest followed guidelines by most of my colleagues the world over, the NCCN guidelines, the National Cancer Network guidelines, surgical metastatectomy is recommended for oligometastatic clear cell and non-clear cell carcinoma as on today. Look at the ESMO guidelines, the surgical metastatectomy for oligometastatic disease, and in all other situations where, for instance, the general condition is good, the disease-free interval after the primary treatment is some say 1 year, some say 2 years, but 2 years, let me be more conservative, 2 years. And if, while you're assessing that case, you feel that it is possible to completely resect that metastasis and not have positive margins at resection. And of course, low pathological grade, low T status, and disease, and at the same time, your disease, which is basically a systemic disease, there is evidence and there's potential for control through systemic therapy. The other consortium that sort of has presented facts and various data collections is the International Consortium Against Metastatic Renal Cell Cancer. 6 factors. They look at 6 factors. They look at the T stage. They look at the completeness of resection. They look at the general functional status, the performance index of the individual. They look at neutrophil count, and they look at ESR. 6-factor prognostication. But let me tell you here, while we are talking about prognostication, these are prognostic indices. Can you hear me, sir? These are prognostic indices, and prognostic indices do not necessarily predict better results at surgery, but are, from the evidence that I shall present to you later, will tell you that the results, when measured in terms of overall survival and disease-free survival, what the results say. And when I talk about prognostication, something that we cannot ignore currently and which has shown merit even in the retrospective studies is the subtyping, the molecular and genomic subtyping of metastatic renal cell cancer. And the content, the messenger RNA and the other things that you look at the molecular level, you tend to divide RCC into 1, 2, 3, and 4 categories, and their biology is different. It is most of these prospective studies that have been looked at in terms of literature, which I shall present to you later. RCC1 and 4 are bad biology tumors. Don't do well even with oral VEGF inhibitors like sunitinib. But 2 and 3, if you resect the metastatic disease after you've treated it systemically with targeted therapy, 2 and 3, category 2 and 3, and you have completeness of margins, the overall survival and disease-free survival is much better. On what basis am I saying it? What is my current existing body of evidence in the statements that I'm trying to make today? These statements, unfortunately, ladies and gentlemen, come only from prospective and retrospective data of case arms studies from databases. Most of the major electronic databases searches, and I'm selecting about 44 studies, more than about 10,000 patients looked at. There's nothing. There are no randomized clinical trials. They are going on. The results are yet to come. Not even one randomized clinical study, double-arm controlled blind study, which would convince scientifically that there is objective responses and the mortality rates are better after adding metastectomy. But yes, huge body of evidence, electronic databases, medium overall survival, ladies and gentlemen, between 36.5 to 142 months after a complete surgical metastectomy. Complete, mark my word, complete. And at the same time, something like 8.4 to 27 paltry months after an incomplete surgical metastectomy. I know that. My retrospective studies and case reports are telling me across the world, there is a decrease in mortality and it's significant confidence level intervals of something like 97%. But all these studies that I shall talk about and what they say after that, let me criticize them before I do that. I'm a critic. I need to look at, these are all small, moderate sized studies where there may be patient bias, where all the oligometastatic diseases and a lot of patient heterogeneity. So really, the scientific value of this evidence is inferior. Otherwise, you go at it site-wise, lung being the commonest. There a group, Zhou et al., as you see, about 1,447 patients 16 studies. Overall survivals are something like 84%, 59%, 43%, 20% at 1, 3, 5, 10 years. Can you believe it? The kind of overall, this is where surgical metastaectomy has been done for lung, where lung metastases have been excised. And lymph node, and in these series, lymph node involvement, incomplete resection, multifocality, size, and of course, synchronicity, where there are multiple, at the same time, multiple sites of these things in the lung. They were all negative in these studies. Another major study, Mayo Clinic, a good 887 patients. This survival at 5 years, 73.6%, had a complete resection. And 19%, just 19% for incomplete resection. So mark the difference. Another major series of about 191 patients from Heidelberg in Germany, overall survival 41.5% for complete resection, and only just 22.1% for incomplete resection. So while I say that there is enough evidence retrospectively, and when you look at case studies, reports, convincing results, physicians tend to believe if the general condition is good, there is no multifocality in the lung, there is just maybe 1 or 2 metastases, there's no mediastinal lymphadenopathy, and the surgeon convinces you that you can get away with a complete resection, then by all means, like the NCCN guidelines say, go ahead. But like I'm again saying, the level of evidence is low. There are no randomized clinical trials. Second side, the bone mets, for instance, there's not much there. In MD Anderson, 295 patients, overall survival at 1 year, 47%. Overall survival, just 11% at 5 years. Massachusetts General Hospital has an overall survival of about 5 years. At 5 years, just 55%. Not bad. But, as far as bones are concerned, local control for palliation and preservation of function is important. So you may be forced to consider that local control if you can't achieve it by another form like radiation. And you're able to do a proper surgical, whether it is resecting surgery for the bone or it is restorative surgery along with it. And if you can think you can do a complete job without leaving negative margins, sometimes in situations where the people are young, they are fit, and all other prognostic factors in their favor, and there is need for local control in the bone, then you have to go ahead for it. And I would say, by all means. Liver metastasis and lymph node, almost the same thing. I've got you results from 14 centers in Netherlands, ladies and gentlemen. 33 patients overall survival is at 1 year, 79%. At 3 years, 43%. Not bad. And Stala et al., 88 patients overall survival at 5 years, 62%, as opposed to 29% for no resection. In complete resection, I'm again repeating, it's a very, very, very important part of my diatribe this evening. In complete resection, which means, in other words, positive margins, significant prognostic factor. So keep that in mind. Brain is not a very happy story. Obviously, it gets the highest priority to preserve CN because you have to preserve CNS function. It can be quite distressing and irrespective of the impact on overall survival, you may have to go ahead with it. Of course, you're competing for SRS. But if it's a solitary metastasis or a couple of small metastases where your morbidity is going to be low, other prognostic factors are there. There are people at MD Anderson report an overall survival of not more than 12% in 5 years. So there are no large surgical series. And I think this MD Anderson series is also a stereotactic radiosurgery series. It's not a surgical series at all. Yes, but if it's a solitary med, condition is good, you're able to get away without because local recurrence is quite high in the brain. So if you think you're in that unusual situation where everything else is for the patient, even when the overall survival will not get impacted, you might be right in going ahead and offering metastaectomy for such patients. I'm mentioning pancreas here because in overall survivals of up to 70% have been achieved in pancreas. And I probably the result is not so much the greatness of the surgeon or the technique, but as it would be the basic biology of the pancreatic metastatic disease being indolent. I'm making this statement, I'm saying maybe because there are no randomized clinical trials to back me up. So, to cut the story short, we continue waging this war and defending the territory of advanced cancer for my surgical oncologists. There is a benefit of surgical metastectomy, but it's controversial. There's lack of high level of index regarding survival benefit. Currently published reviews support surgical metastectomy in selected patients, and I talked to you about the prognostic factors that I talked about. Complete surgical mastectomy allows sustained free survival, free of systemic therapy. Theoretically and potentially, yes. Particularly in today's day and age where therapies are expensive and patients can get treatment fatigues. And perhaps integration of surgical metastectomy and current targeted therapies is a valid option. Pending results of ongoing trials, ladies and gentlemen, they are yet to be reported. Would be happy to fill you in at a future date when these results come in. Current studies, of course, suggest an additional therapeutic value of surgical mastectomy when done prior to the targeted therapy, as opposed to when done after the target therapy. In intermediate risk metastatic renal cell cancer, the RESORT trial has already told you that risk stratification is the key. We've got to get better at risk. Like today, you're using risk stratification to sequence targeted therapies in metastatic renal cell cancer. My medical oncology colleagues, I would request my surgical oncologist colleagues to be more welcoming of more research and more evidence-based practices in future, and perhaps risk stratification when we get better at it and we get predictive factors as to which are the patients who will get objective and evidence-based better responses if we had metastectomy. And of course, that has to happen at a multidisciplinary meeting. Decision-making has to be multidisciplinary, and everything needs to be looked at. Predictive factors need to be enunciated, all a matter of ongoing trials. So, if I send you back and I say today, with all the prognostic factors in the favor of a patient, oligometastatic disease, otherwise fit patient, and overwhelming physician confidence based on multiple prognostic indices, even without randomized clinical trials supporting me, let me be brave that let metastectomy be given to the right patient. And if you feel satisfies these things, go ahead and do it. Otherwise, wait for randomized clinical trial results to come. Thank you very much for lending a patient here.
Thank you very much, sir, for the great presentation. Initially, we missed Dr. Advani, sir, in the beginning. So, may I request Dr. Advani, sir, to take over, please, and share his wisdom with the audience. Over to you, sir.
I think you have discussed almost everything that was supposed to be discussed, and I really do not have anything more to discuss over there. Hello. So I think there's really very little to add in this situation. Go ahead, Vidya.
Thank you, sir. So we'll go with the third presentation by Dr. Ullas Batra. Sir will speak on non-clear cell variety of RCC. How do I treat? Over to Dr. Ullas.
Thank you, and thank you, Dr. Sahu, for asking me to speak about non-clear cell renal cell carcinoma. How do I treat? My first question to this, my answer to this is not how do I treat. My first question, Dr. Sahu, is, Dr. Sahu, when was the last time you gave me a simple topic? So when you asked me to talk about clear cell RCC, I thought, I'll be speaking about clear cell RCC and all. But then I saw, Dr. Raja speaking about that, so I had to speak about the non-clear cell RCC. My second thoughts when when I discussed, when I thought about the non-clear cell RCC was actually my DM exam time. And the one night before exam, I was like, non-clear RCC, ये chapter छोड़ देते हैं, ये exam में नहीं आएगा. And non-clear RCC was like, beta to kal min, I'll ask you this. And today, Dr. Sahu, you're asking me to tell how to treat non-clear cell RCC in front of the entire audience. It's okay. I'll try to do some justice to it. So, let's start about non-clear cell RCC, which is called as NCC RCC. So, NCC RCC is not one disease. I thought 80% of the renal cell carcinomas are RCCs, 20% are NCRCCs, but they are different. They are into papillary, they are chromophobe, they are medullary translocation, collecting duct, mucinous, spindle cell, carcinoma associated, follicular renal cell, cystic RCC. So what I basically want to tell everyone is that NCC RCC is not one disease. We need to understand that. In this 15 minutes, I'm going to talk about how to treat this NCC RCC. And even more worse, they're actually molecularly, not only are they biologically diverse, they're also molecularly diverse, and that is because they have got some different mutations, like papillary RCC has got c-Met, type 2 has got fumate hydratase, HLRCC has got other mutations. So what we know is that NCC RCCs are molecularly different, which is also they are not one disease. That is what was my first gyan when I learned about the non-clear cell RCC. So what do we already know? I'll go back to my knowledge about when I was reading about non-clear cell RCC. What do we already know about NCC RCC is that, again, RCC is a heterogeneous disease. It can spread from a spectrum of high intermediate aggressiveness to intermediate aggressiveness to non-malignant. Now, the non-malignant are the oncocytoma or the papillary adenoma, and the higher ones are the collecting duct and the renal medullary. Papillary type 1 is intermediate. Papillary type 2 is more towards the high aggressiveness. And clear cell RCC is in some way non-malignant and intermediate. So, non-clear cell RCC is not one disease. Not clear cell RCC is not one molecular, it's a molecular diverse diseases. And they all have got different malignant potential, so you cannot club them together. What we also know is that non-clear cell RCC has a worse prognosis than CCRCC. That's a clear cell RCC. And that was the graph which is being shown over here. The blue color is the clear cell RCC and the non-clear cell is something in the red over here. Even in the non-clear cell RCC, you have a different prognosis with papillary doing, with chromophobic RCC doing better, papillary RCC in the red doing slightly lesser, and the undifferentiated RCC actually doing the worst. So again, NCC RCC worse than CCRCC, and even in NCC RCC, chromophobe is better than papillary is better than undifferentiated RCC, and that is what we already know till now. So what we can know is that definitely non-clear cell RCC is an unmet therapeutic need, and we need to define more and more different strategies to deal with it actually. So how do we solve this enigma? What I read is we have 4 approaches have been tried till now to solve this problem. So the solution to every problem is having 4 approaches. And the first approach, which was there when probably Dr. Sahu and I were doing our DM not together, but Dr. Sahu was ragging me in my DM and I was getting ragged over there, was a mixed bag approach. That is, you take papillary, chromophobe, translocation, collecting duct, medullary, put them all together and do clinical trial. So at that point of time, we had 3 randomized clinical trials which were done. One, which was the ESPN trial. Second was the Aspen trial. Third was the Record 3 trial. So you take all non-clear cell RCC into one. 3 randomized clinical trials have been done. All of them have compared sunitinib versus everolimus. And let us see what the data is. So I'll just briefly go through this data. The Aspen trial basically compared everolimus versus sunitinib. And the dose of everolimus was 10 mg, sunitinib was 50 mg, 4x2 schedule. And what we basically found out was that although the PFS favored sunitinib, the OS was not significantly different for sunitinib versus everolimus in the mixed type subtype RCC. So you can take, if you take the group as a whole, PFS was better with sunitinib, but the OS was not better for sunitinib. And as you can actually see over here, the papillary and the unclassified did better with sunitinib, and the chromophobe did worse with sunitinib. So we didn't exactly know that what did better with sunitinib, what did better with chromophobic. We didn't know. The second study was the ESPN study, and we are not talking about the cricket ESPN which Dr. Raja very rightly showed. Again, sunitinib was compared with everolimus, and here a crossover was allowed. And again, in this, we found out that although the PFS slightly favored sunitinib, but there was no OS advantage, and if you allowed the crossover, there was no difference whatsoever with that. So the problem with the mixed bag approach, that is the solution one approach, is that we are clubbing papillary as similar as chromophobe, as similar as unclassified, as similar as translocation, as similar as sarcomatide, which is not the right approach. Sunitinib works slightly better in papillary and chromophobe, but slightly lesser in the sarcomatide. And when the numbers are small, just look at the numbers 14, 6, 4, numbers are not very, very good. So that's a problem with a mixed approach, mixed bag approach. And this way of dealing with things has really been, has taken a backseat right now. So the results are not clear, and this was happening till 2017. Results are not very clear. So now let's go to the option 2. I told about the first approach, that was the mixed bag approach. The second approach is the histological bag approach. Let's just take type 1 and type 2 papillary RCC. After that, give them sunitinib or cabozantinib or crizotinib or savolitinib. So this was, you take one kind of a rare RCC and then divide into sunitinib, divide into all the 4 drugs over there. But the problem with this is theoretically fantastic. However, it's a very slow accruing trial. In fact, the PI of this trial actually showed over there that they could recruit only 0.4 patients per month in this trial, and that is why the results of this trial is not yet out. So, one was the mixed bag approach, the second was the histological bag approach. The third and the most common thing is the biological driven bag approach. That is, you look at, so this was the 3 abstracts presented at this ASCO 2020 about the Savoy trial, and there were 2 other trials which looked at the biological driven bag approach, that you do an NGS for all of them. So this makes more sensible. You look at whether it was almost like a basket trial, and you find out whether something really works or not. So this was the trial which was presented by at ASCO 2020. This is called the Savoy trial, which basically said that you took out all papillary RCC, do an NGS in them, find out for the MET mutation. If you have a MET mutation, randomize them into sunitinib and savolitinib. And this trial actually was stopped early, but if you can see over here, this was stopped early because they found that the savolitinib has got much more activity in the MET amplified and MET mutated tumor, but there was a definite high response towards savolitinib, and there was a trend towards OS advantage, and probably this is the way to go further in the non-clear cell RCC also. Now this was another study which was presented, and this was, they took even more rarer tumor. They took the advanced hereditary leiomyomatosis and renal cell cancer or a sporadic renal cell cancer, and here bevacizumab plus erlotinib was used basically. And again, they found out that if you have a HLRCC, that is the hereditary leiomyosarcomatosis, and RCC group, you had a PFS of 21.1 months. However, in the sporadic group, it was 8.8 months. So probably the biological driven approach is the right approach over there. You do an NGS for the person and then probably find out what is the mutation which is driving it. Something akin to what we do in the lung cancer. How can I not quote lung cancer in any of the talks that I give? But again, these are all the rare tumors. And then came the fourth approach probably. The fourth approach was what I call the actual savior approach. The immunotherapy trials, which is the bahubali of all the medical oncology right now. I'll put 2 trials over here. first line pembrolizumab monotherapy was tried in advanced non-clear cell RCC. So the cohort basically, if you have patients with advanced RCC, the cohort B, which had 165 patients, took pembrolizumab. There was no comparator arm on this. But if you see over here, the overall response rate was 26.7%, and the disease control rate was 43%, with a CR seen in 6.7% of people, which was fantastic. And look at this. The KM estimate of OS in the total population, the cohort B, was 28.9 months, which was far, far, far better than the 13 months which I showed you when I showed you the initial data of sunitinib and everolimus over there. So this definitely was an improvement. And the authors concluded, this was again from ASCO 2020 this time, that anti-tumor activity of pembro was shown in non-clear cell RCC, including all the IMDC subgroups, all the PDL1 status and sarcopenia differentiation. 19 of the 44 patients who responded had ongoing response, again what Dr. Raja showed very easily. And again, very importantly, patients who had a more than 80% tumor reduction had survival rate which is similar to people who had achieved a CR. So you don't need to achieve a CR. You probably will. If you have 80% reduction, you're going to do as very well over there. Now, my last slide. There was a question asked about the sarcomatoid carcinoma in the chat box over there. And sarcomatoid carcinoma, I will just show this. And these are not current origin. Senthil has popularized IU combination by saying IIU combination. I am going to say Nivo AP as Karan Johar probably. And this data was published in the AACR group on September 1st, 2020. And if you see, Nivo AP was compared against sunitinib in first-line treatment of patients with advanced sarcomatoid RCC. And look at the PFS that we have achieved with the Nivo AP combination. That was 26.5 months versus 5.1 months in Sutent arm. And that definitely was very, very impressive. And if you look at the overall survival, you have 14.2 months versus not reached. And that was definitely fantastic. And I think for this, Nivo EP or Karan Johar or Karan Arjun actually deserve a standing ovation for that. So, Dr. Sahu, to your question about non-clear cell RCC, how I treat, I would like to rephrase this statement as non-clear cell RCC. What I have learned, it's not a single disease. They're heterogeneous group of diseases. They were early treated with a single group of TKIs, mainly sunitinib. They got a worse prognosis than clear cell RCC. NGS may have a role to play, although I'm not advocating NGS, but definitely if you have a MET mutation, I would like to give MET inhibitors. Single agent immunotherapy has shown impressive results in KN427, and Nivo AP combination is highly active in sarcomatoid RCC. And with this, Dr. Sahu, if you can see, this is taken from last year, December 2019 conference. So this is from the three of us. Hopefully we meet again soon. Thank you. And I hand it back to the organizer. Thank you.
Thank you so much, sir, for such a marvelous presentation. Now I would like to invite Dr. T.P. Sahu to moderate the panel discussion. Thank you.
Okay, am I audible now?
Yes, sir.
Yeah. Thanks, Ullas. I knew you will always do a good job, and as usual, it was nice to listen to you. And about now coming to the last part of it, before I start, thank you, Dr. Advani, for being there in the panel, and I would always love to have your expert comments whenever it is there. And if some of us is going wrong, so you can just pitch in. So it's a short panel of 40 minutes. We'll make it to 35 to 40 minutes so that we can finish on time. And all the other esteemed guests are more than happy. I'll be more than happy for them to pitch in and just add a comment, because I feel this is a very important topic, very rarely discussed. We always have been speaking about lung cancer, breast cancer, and these topics do get left out. And I feel it's more interesting to do some webinars on these topics. So that's much more to learn when we present such things. So I'd like to invite all these 6 panelists, Dr. Ghanshyam Biswas, who's a dear senior colleague, who I've been seen him through my MBBS days. We have been one batch senior to me. He has been one batch in my same medical college. Ghanshyam bhai, welcome. From Bhubaneswar, oncologist, Niti, dear friend. We did DM around the same time, 1 year. A friend here from Bhopal, roots from Bhopal, but now based in Bangalore, moved to a better city for better prospects, leaving me behind in Bhopal. So that's Niti for you. So Reshma is there in Pune, a medical oncologist. Chandan, a friend, dear colleague from PGI Chandigarh. Aditya, Bangalore again. And Bovin, nice to again connect with you, is from Kerala, Trivandrum. So coming to the topic now. What does a patient want at the presentation for metastatic disease? I'll skip this because I know all of us will tell that the cure is a rare possibility, but all the patient wants to live longer with good quality of life maintained. So now coming down to this. Niti, if I can take first your comments, what is your minimum workup for any case that comes down to you as advanced RCC? Is PET scan, or PET scan is something that you don't do for all the patients?
After the histopathology confirmation, I would prefer either a CT chest, CT abdomen, pelvis, or to do a PET scan. I know for renal cell carcinoma, for kidneys per se, it's not a very good imaging, but we would possibly have an additional imaging, and PET scan is good for metastatic disease. So I would generally do a PET scan.
Okay, Dr. Ghanshyam, anything specific in PET scan which goes over, as Niti really pointed out, that for something as operable disease, it's not a very good modality where surgeons are very comfortable. HRCT chest and CT scan sometimes good enough. Anything as a medical oncologist, PET scan, you want to do something which you really get more data rather than a CT scan.
I don't think you do, because PET scan might pick up some non-added uptake also, and we are not sure. So that is going to help you in diagnosis or not. The PET scan may be a one-stop solution, because if the alkaline phosphatase is high, so probably again we have to add on a bone scan for such patients. So in that case, probably a PET scan will be a better modality.
Chandan, to pitch you in, 2 things. I would tell that PET scan is superior for probably the bone scan for bony mets. That's point number 1. Point number 2, if I look at tumor thrombosis, whether it's a tumor thrombosis or not, PET scan picks up it much better. Am I right on this part? Do you agree to this part of my PET scan conclusions?
Agree.
So now, Chandan, one more thing which I wanted to ask you. In PGI, do you do PET scans or a CT scan as a routine? Or
You're muted. You're muted.
hello?
Chandan, I'm not able to hear you.
Yeah, most of the times it's CT scan, and we do definitely do PET scan also. But I must conclude PET is a better modality to identify. The sensitivity of diagnosing bone mets is much higher as compared to CT. It's around 75 versus 90%. That's the difference.
And what about a tumor thrombus? It's a much more better modality to do
Tumor thrombus too, because the surgeons always want the tumor thrombus is actually eroding the blood vessels or not. In that context, the CT is a better modality as compared to PET.
But there is also some data. There's some data also to pick up whether there's a tumor thrombus. Really, tumor thrombus PET picks them up better. But we'll stop here and to ask Aditya, would you do MRI routinely for every patient who is having RCC, or you do it for only symptomatic patients? A quick yes, no.
So, routinely, definitely no. And as the previous panelists have said, advanced disease, one-stop imaging, PET scan is one thing which serves all our needs.
Okay.
If there is a specific reason, if we are thinking about operating somebody, or if we know that if there is some kind of a hematuria going on, then maybe MR. But one-stop imaging should be good enough.
So to conclude, PET is, although it has advantages, you can always get away with doing a good CT scan and a bone scan. But PET could be advantageous if there's a metastatic disease, you want to quantify the disease. But one more thing PET could be helpful, which I find is if you're doing a TKIs, sometimes CT scan do not pick up the lowering of activity. So that also probably helps us. So that's where it is. So anything is okay, but whatever you do, be constant over what you're going to do. So now the next thing is to Reshma. Dr. Reshma, do you really risk categorize every patient? in the Indian scenario where 90% are unaffordable for anything?
So most of the times I do try to risk stratify because then it does help us to guide the management. At least we can stratify the good risk into poor and intermediate. So even though these risk criteria have not really been validated as per their relevance in the current era, but still they have been used in trials, and that is how they help us guide therapy. So as much as possible, I try to risk stratify.
Okay, so you still...
In the first line, not in the subsequent lines, or in the first.
I really put this up, really risk categorized. I'll tell you very honestly what I do. 90% patient cannot afford beyond a free student. So really then I feel, do I really need to risk categorize because I do not go beyond that. But I do agree that once the affordable case comes in, I do take the effort of risk categorization. So Dr. Niti, which risk categorization do you follow? The MSKCC or the IMDC? And for what reasons do you follow which one?
MSKCC risk stratification is what I follow because it applies to most of the situation, whether you're trying to use immunotherapy or TCAP-based therapy.
Okay, so you are using MSKCC.
And I would want to risk stratify all the cases to at least prognosticate them. I mean, tell them how they are.
Agreed. So you can talk to them really how the patient is going to do. That's fine. Chandan, MSKCC or IMDC?
IMDC. I tend to do almost every patient categorized, but finally I may give a TKI.
That's fine. So why IMDC? If you told is for MSKCC, why are you for IMDC?
So there are few patients those who can really afford the TKI. I actually goes for the IMDC, and depending on that I will give the TKI. In fact, the Pembro XG actually. Those who are afford, I tend to give Pembro XG also.
Okay.
For me, IMDC it's much easier. You have to do a CBC and the calcium only, right? So
all of us agree that the categorization is required. We need to prognosticate them. That's why final for on the panel. I just put it up because there is a difference in what it is. The basic difference is the lactate dehydrogenase goes away and the neutrophils and the thrombocyte counts comes in. So basically that one of the panel told that you just need to do a CBC which will take care of the anemia, the hemoglobin, the neutrophil, the thrombocytes. The rest two are clinical parameters and you just need to do a calcium. So that really gives you the easy part of it. So that's what is speaking of. If you look at here, it was my point against Niti, what it was is the MSKCC is mainly inclined for the interferon era. So is it really valid? That's something which you want to put, and there's a beautiful thing that came up which was put up in last year, I think so, which was a analysis which was retrospective in 176 patients in metastatic RCC with treated with TKI as first line, and this was over 10 years period. They looked at agreement and disagreement between MSKCC and IMDC. And 77% there was agreement, and 1 quarter there was disagreement. And look at it, the majority of the disagreements when they found that they upgraded the MSKCC intermediate to the IMDC poor risk. So actually, if you look at it, this is where there's slight differences in the quarter of patients. You do find the majority of them from the intermediate will go on to the high risk. Anyone wants to pitch in a point here before we move on to the other topic and other things? Any other panelist? Quick point. No? Okay. So, what do you have, Dr. Ghanshyam? This is a beautiful slide which I put up. And for Niti, I will just come in. Do you do the intermediate 1 and 2? Means 1 risk factor intermediate or 2 risk factors? And look at the difference in curves. There is a definite difference in curves in 1 intermediate risk factor and 2 intermediate. Dr. Ghanshyam, any point you want to speak on this?
So for me, a favorable and a poor makes more sense than this cohort of patient which comes in between.
Can you come again?
So for me, a favorable and a poor risk that stratifies treatment rather than the intermediate group which makes not much difference to me.
So it doesn't make a much difference to you. Bo, if I can bring you here, do you agree with this statement?
Yes.
So for you, it's a poor or high risk. Intermediate does not make a difference to you.
It does not make a difference because practically it does not make a difference. So I don't think on the theoretical basis we can have this discussion, but on a practical basis, I don't think it makes a big difference.
Don't you think 1 and 2 risk factors, 43 months versus 22 makes a difference? Because when you're speaking of the survival, there's a gross difference. Chandan, last point.
Yeah, if you want to use Vivo EP, then you can differentiate between 1 and 2. in one risk factor, you can get away with TKI. In two, I think you must give, if you have no problems, you can give IO combinations.
I think so. In immunotherapy era, this would make a difference. I think this we have to start getting more careful about this, but fair enough. We take this point. So now come to a case, a hypothetical case. A 57 years old male OPD, he comes to OPD with a cough for 3 weeks with increasing intensity. It's the renal mass, bone and lung metastasis. We have done a biopsy. It's a clear cell variety. It is intermediate risk factor, and we put it let it be 2 as per MSK-CEC. We did the MSK-CEC. And how do we proceed? Any takers for surgery? Woman, surgery.
No, because this patient does not have any indication for surgery because it does not have any bleeding or anything like that. So we are not going to benefit out of surgery. So no surgery.
Pre-Caramina. Let this patient presents with would you do a surgery? With a disease bulk 90% in the kidney, there is a 10% disease bulk outside of the kidney.
In that case, yes, definitely. If the bulk of the disease is inside the kidney, yes, I feel like okay, that patient might benefit out of that thing, and I give the option of doing an upfront surgery.
Even today? No.
That's what. It depends upon the scenario. Discuss with the patient. If the patient is okay, and then I know the evidence is actually moving away from that.
That's okay. Aditya, agree if today the majority of the disease is in the kidney, there's a metastatic disease, you would offer a surgery still in the intermediate?
No, I disagree because at least in a post-Carmina era, especially if the option of IO-TKI or IO-IO combination is available, then probably it does not make too much of sense in offering a metastatectomy, offering a cytoreductive nephrectomy.
Chandan. Yes.
The Carmina trial based on the IO therapy, right? The response rate is only 30%. So in 2020, I have therapy that can reach the ORR of almost 60%. Then I don't think surgery is getting more and more obsolete now, at least cytoreductive nephrectomy. And if I stratify the Carmina depending on the risk stratification, cytoreductive surgery is only for the good risk, not for the intermediate and poor.
Okay. Reshma, let's assume that you get the IO, and let's say TKI. You give a TKI for what the reasons. This patient somehow does very well. Again comes back to you in 18 months, still has a very good response. And would you consider a cytoreduction later on? Have you ever done that? Would you consider that? Do you have data for that? 3 questions.
Sir, if he has a very good response, and there is data for delayed cytoreductive nephrectomy. So we can offer them this option if there is a good response. Tumor bulk is in the kidney, because even though the survival data is not there, but there is some data for delayed cytoreductive nephrectomy.
Niti, with your experience, Reshma tells there is no survival data. To my knowledge, that the curves really separate out. Do you think there is an advantage of going and offering some patients a delayed cytoreduction?
You actually answered it. For very unique subset, yes. If a patient has had excellent response, I mean, let's say the bone disease and the lung disease has shown extremely good resolution, and there's a small residual disease in the kidney. So in that situation, it might be a unique situation in which probably an interval cytoreduction might be.
Anyone in the panel has experience of delayed cytoreduction in any of the patients?
Yes, I have experience. One of my patients was on recently underwent. He had excellent response to TKIs, and then because the patient symptomatically became better, weights, he had a significant gain in weight. The metastatic site had a significant reduction, and the option was given to the patient in fact, so it went ahead with the interval cytoreductive surgery.
So basically, all of us agree that at this point of time, with this era, cytoreduction at the upfront should be not put up for the intermediate. Low risk, it's fine. And if there's a very good response, there is data, something that's evolving for the delayed cytoreduction.
Yeah, the people.
Can jump in.
So I have another experience. So the patient was doing well. So sometime back, the patient actually had too much of local symptoms. So pain, hematuria, so that happened. So there I had to consider a delayed surgery. So it is in contrary where the responses was not good, or the patient progressed from the initial treatment and the local symptoms were much more. So the patient needed actually a local care. So that was more important So, that's another scenario.
So now we come down to Aditya. So this patient, no surgery. So which is a combination of choice? Intermediate risk, metastatic, bone and lungs, QSL variety.
I think
Dr. Raja.
I think cross-trial comparison might not be too fair, but I have had 3-4 patients with this combination in whom I have used IO-TKI combination, one of whom in fact achieved a complete response.
So this is the IO and this is the TKI.
IO would be pembrolizumab and TKI would be axitinib. So since the time that the pembro axitinib data has come out, I have used them, and having seen a complete response in a metastatic disease, that did blow my top off, and I'm actually quite favorably inclined to that. And just to make a point about previously what Dr. Boban said regarding the delayed cytoreductive nephrectomy, I think that approach will help us select with the disease with the favorable subtype. So if a disease is responding to TKI, that's when we try and do more interventions to prolong the survival.
I think all of us agree that there is a very select patient who can go for the delay. Will stop the surgical part and cannot come to the meta part. And then TKI with ICI or IO what our previous speaker spoke.
Both are correct, but
what do you choose?
In the present situation, I can choose pembro and axi because it's very difficult to it's difficult to procure the ipilimumab. So
if it is available at this point,
I would have chosen that also. But the point why actually saying Nivo EP is I think I may choose Nivo EP because EP is given for the four doses, right? It's only for 4 doses. And after that, you have to stop the EP and then continue with nivolumab. There is no long-term kind of giving ipilimumab.
Yes.
If you compare the TK and IO, pembrolizumab has to be there, but TK has to be continuously throughout the time period. So in that way, EP may be a better option. But
apart from that, if I have to choose, I know both these things are approved. We saw that. But the highest response rates ever seen in RCC has been with the IO combination.
Yes.
So in that, if a patient is affordable, what stops me, Rishma or maybe Dr. Ghanshyam, anyone can come in after that. How do you select a patient between a IEP and a Nivo combination versus a TKI and a immune checkpoint inhibitor?
Sir, I just want to comment one. The early progress, if the IO combination is higher as compared to the IO and TKI, if you are
17% versus 10%. That I saw that. The data is there. So I will come to that in a detail. Reshma.
So there is no head-to-head comparison between both of the arms which you have said. So what we have good response rates with the IO combination. So but considering I have no experience by using ipilimumab, I have used exotic pembrolizumab. That is why I have used it in 3-4 patients. Unfortunately, those patients couldn't continue it. They had good responses, but because of the money issue, couldn't continue it for a lot of time. But since I have experience with exotic pembrolizumab, I would prefer that.
Niti, your choice, and then Dr. Ghanshyam. The same thing comes in. When we speak to our patients, do we counsel them enough that you have to take it for a particular considered period of time? So if that is not done, did we benefit the patient or did not benefit anything? And what will be your choice? Yeah.
So my choice will be IO plus TKI. If I have finances which allow me. As Reshma also said, IO plus IO and TKI plus IO have not been compared in 1:1 comparison. So we really don't know whether it's superior. And of course, I don't think we have too much of experience, at least in our country, to use EP.
Okay.
So I generally use IO plus TKI.
Dr. Ghanshyam.
So I have an experience of a patient who had early CKD with the comorbidities. So he was somewhere started on pazopinib, came to us 2 weeks later with GI toxicity. But once there was component, the patient was switched over to axitinib and pembrolizumab. So he has been doing good, so no toxicity. Now the problem is that every time he comes, so doctors are not ignoring him like that, which is a very difficult scenario. So that's the issue.
Moment before we move on, a combination. Which one first? With the TKI and IC. If I see on the NCCN, that is also the third approved drug which is there as a first line. Anyone? Or anyone has experience with cabazantinib? No? Okay, we move on. I think that is the third drug that is approved. Debulking surgery, I'll just skip because we have spoken about it. So this is what it is. So we'll go to, there's a rationale for combining the immune checkpoint with the VEGF TKIs, because the VEGF TKIs actually augment the immunotherapy action. That's what it is. All of us know this. Just to come to one point of it. Does anyone do any PDL testing? Chandan, do you do PDL for any of your patients whom you consider? Do you do that?
No, sir. No.
Okay. Anyone in the panel does that? Anyone does tumor mutational burden, TMB, something to keep better?
So we have done in the past, but not recently. We are not doing. So the PDL one. Initial days, the recurrent metastasis patients, we have done few patients. So the last 2 years we are not doing PDL one.
Okay. So tumor mutational burden, no. PDL one, no. That's the two thing that's coming out of the panel.
The only thing is that we don't do PDL1 at all, but in some patients we ask for the somatic mutations panel. So that normally will include tumor mutation burden, PDL1, and spectrum of mutations. So I mean,
any lab where tumor mutation burden is validated in India?
No, most of these what we send would be foundation one. So
okay. That comes out. Yeah, Chandan, you want to tell something about it? No, all this. That's okay.
No, it's
okay. So the only thing that comes out, this is what it was speaking about. So if you look at it, if you look at the pembrolizumab, the progression disease is around 10%. It is 17% to sunitinib, which is actually matching the data for the immuno combination. That's also the progression 17%. But look at the CR rate. The highest CR rate comes with the immune combination, and that's the one point of the immune combination. Not only the response rate, even this combination. All of us have seen this. I'm going to skip this data. As the data difference, there is no group that really is superior or inferior. Javelin, as Dr. Raja told, I'm not going to tell about it. We know that the axitinib, avelumab, the OS data is, all of us know that. But here again, the response is not much different for the PDL1 and the overall population. It's actually the same. So PDL1 does not much score over the overall population. The same thing on the curves which are seeing both the PDL1 positive overall, it's actually the same. So the OS is no different. I'll just come to this part of it. That, yeah, combining. So which Chandan told, I'll just come here. Just look at this part. The progressive disease is little higher for the EP and nivolumab, but the complete response rate are still the highest in this group. And the response rates are still the highest what has been seen. So can we conclude that if I have a bulky disease and the disease load is high, I would be more comfortable if everything is there and EP comes to the market, I'll be combining both? Reshma?
Yes, so from this, because of the higher, yes.
Okay, Chandan, any points?
So I use for just one patient only, but I feel it's a doable.
What is the data? I understand all of us are very rare experience. With the data, do you feel for bulky, because of the response is more, you'll be more comfortable doing the EP and
Yeah, I'm happy to use. I have no problem in cipilimumab.
More symptomatic and bulky disease, probably the combination will be better, no?
I think the most important point, just to make the patient understand, it's ipilimumab requires some time. There's a time lag to prime the lymphocytes, right? So you actually have a patience for a few more times, then it will work beautifully.
Women, any experience with the EP and nivolumab?
No, I don't have any personal experience.
So now do you feel there's a patient selection where you would like to use it? Because if you look at the data which Dr. Raja showed, which I will just skip because that is also data, that it is a response to this combination. It has the highest, the flattening of curves happens with this combination only. If there's a response in the responders, actually the curve plateaus out. So do you feel that this is the combination for the future?
Yeah, theoretically, yes. It looks like the data looks very promising and definitely it's going to be in the future. But as of now, from the practical point of view, I don't have any experience, but hopefully in the future we'll be able to use it.
Aditya, when it comes in, the market is full. Are you convinced or still you will be watching?
So, Dr. DP, the issue here is, see, as per data, the IO-IO combination is good, but the actual googling the picture is what happens to patients who progress on a IO-IO combination. Would you really want to use a TKI? And if somebody has progressed on the IO-TKI combination, then what else to do? So, I think there are more questions than answers for this issue.
Great. But at the first line, that's what we are speaking about. What the data tells you, again, the PDL1 does not change. The only thing this curves tells you that sunitinib is the inferior arm. That's what it comes out. Both the black lines are the inferior one. This is what it works. Yeah, this is what the curves are. The nice separation for the responders.
If the possibility of drugs is there, then IO, yes. And then second line, we can think of cabozantinib.
Exactly. I was coming to the second line. So let's assume if a poor patient, which 99% of my patient category is, which is the TKI which one chooses. So what I conclude from the combination first line is that because of the experience, and if he is not there, we are a little skeptical. We are choosing the combination of pembro and axitinib. That's the first number one choice. Cabozantinib, although approved, people are skeptical because we are the drug that is unknown to us till now. The thing is that IO looks the most promising, and all of us will like to use it. The data is the most promising among all of us. That's the fine for the first line. If TKI, which one? Dr. Ghanshyam, which?
No, so we have already moved to pazopanib.
You are a pazopanib guy. You are a pazopanib guy. Okay, Aditya, quick.
If cabozantinib is available, I would want to go with cabozantinib in an intermediate poor risk.
So you would like to go to cabozantinib, but if it is available, what is the choice now, pazopanib or sunitinib?
Sunitinib,
sunitinib.
2 weeks, 1 week off is good for my patients.
All of us do that 2 week, 1 week. Chandan, which one?
So the patient-friendly pazopanib is my choice.
Okay, Niti?
One of the two, sunitinib or pazopanib, generally sunitinib.
Generally sunitinib. Reshma?
Sir, if affording sunitinib, if not affording pazopanib. Pazopanib, sir, is more tolerable.
Both turn out to be the same cost in 1 year. That's the real data. Woman, which one?
Sunitinib.
Okay, I am a sunitinib guy myself, I'll admit that. If there's chance, I go to sunitinib just because the bulk of the evidence has come from that. I feel comfortable now managing the toxicity. But pazopanib is a friendly drug. There's no doubt about it, and there's nothing wrong about it. To tell you, all of us know this, both are equal. Pazopanib was patient preferred. The tivotinib was better than sorafenib. We saw that on the data. The cabozantinib is better than sunitinib in regards to response rate and PFS. The OS data is still there. In the Indian scenario, we have spoken. We'll skip this. Just to tell you that one data which I could pick up, I maybe missed some data. I'm sorry if anyone is published, I could not pick it out. This is data from Kidwai, my alma mater. They have a small data. You can criticize it, but all this says that sunitinib, pazopanib both look same. The sorafenib is the inferior one. Coming down to which question was asked, how do we sequence? If you look at the metastatic RCC progression to first line, maybe at TKI, then cabozantinib, Lenva, everolimus, and nivolumab comes in. So, any takers for everolimus? Anyone who use everolimus at this era as second line?
So, yeah, low dose everolimus with the lenvatinib.
So, you use low dose everolimus with lenvatinib as a second line?
Yeah.
Okay. Phase 2 data you are quoting. Okay.
Absolutely.
So, that's your preferred second line, lenvatinib and low dose everolimus.
Yeah, absolutely. Because the standard dose of everolimus definitely the toxicity, and a second line IO for most of the patients is not affording, so that makes a better choice in the patient scenario.
And then what is the second line choice?
My options are nivolumab versus len everolimus.
So that's again the two choices coming. Niti, your second line choice?
Generally Nivo, if not given in the first line. I mean, if IO was not given.
That's fine, agreed. If not given, it's a second line choice for you. If not Nivo, affording for Nivo.
I mean, I would consider either single agent axitinib or if I have given. So, I mean, we have generic axitinib also.
Yeah, and now we have generic axitinib.
And Lenva, everolimus, I would possibly use later down. So, I have third line if possible, then yes.
There is the data to that. Actually, this is one combination which is active and on third line. So, to be fair to what Niti told, this can be reserved for even the third line. And there is activity still of the Lenva and everolimus in the third line. Very fair comment. Reshma, second line choice.
The second line choice is say single agent nivolumab most of the time. And if the patient is not affording, so nowadays a lot of generic drugs are available like for Exited. So we are if not affordable for nivolumab, then any of the generic options.
Okay, Bowman, any thoughts?
I prefer everolimus single agent also because I have seen good response in a good number of patients. But the thing is that we need to know how to manage the toxicities. Now all of us know how to manage the toxicities. So yes, everolimus.
Are you really convinced that it's the best agent as a single agent?
It works not in all the patients, I'm saying, but then if it is working, it works. So that's my trick. If it's not working, I will add lenvatinib to that thing. That's the way.
So can I conclude for this line that cabozantinib, if available, is a good choice for people? Otherwise, nivolumab is definitely what people prefer. Because it's not there, we are there at takers and is distributed between lenvatinib and the low dose everolimus. So this is the data which all of us spoke about, and it is a very clear thing that everolimus really is the inferior arm in most of the trials. And definitely sorafenib is not there at all here. I'll just skip this to tell you which sequence makes better. There is a data for that. If you criticize the data, it is the sequence which was pulled out post pazopanib or sunitinib, which is the data after TKI, which is the most affordable thing. It comes out for two things. That the blue line is the nivolumab. So nivolumab is the most cost-effective sequential therapy. The second one is cabozantinib. So these are the two most cost-effective sequential therapy after a first-line single agent TKI. So any different ethnicity, anyone can take it. There is data for that, toxicity versus efficacy. Bowman.
Yeah, definitely. Ethnicity plays an important role. All of us agree to that thing. But then we don't think
in regards to toxicity, or
both the ways.
Okay, that's it. Aditya, what is your point? Toxicity and response.
Especially with regards to toxicity, ethnicity definitely makes a response. Different because response-wise we know that there is difference, but especially when we use sunitinib and just like you, I am also a sunitinib guy. So for us, when we started with using 4 weeks on, 2 weeks off, it was terrible. Then we shifted pazopanib, and when 2 weeks on, 1 week off came, even in that, most of the times I end up going down to 37.5. So Asian ethnicity, the tolerance is definitely lesser than Caucasian ethnicity.
Okay, Ghanshyam, any thoughts on ethnicity? We agents do differ in toxicity, outcomes, or both.
We have seen with capsicum, we have seen with GFR and these are also all the same. So probably our patients, our population are a bit different.
Let's see what the data is. We may assume a lot of things. The data is oncological data. It's probably pulled out from all the publications, the more than 1,500 publications. It just points out two things. It is the Caucasians and the Asians. Just look at the hand-foot syndrome and thrombocytopenia. And these are the two toxicity which really matters in Asians, which were much more, but the outcomes were no different. So basically, it points to a conclusion. Asian patients more frequently experience sunitinib-based toxicity such as hand-foot syndrome, fatigue, and thrombocytopenia compared to Caucasians, but there was no difference in efficacy. This is what the data stands. Anyone wants to counter this? Chandan, you want to tell something?
What we are actually, we are not Asians, we are not Caucasians, right?
We are more like Caucasians. That's what people are telling. Yeah. We are the darkened Caucasians. That's what it will be more likely. So there is one data which I could put up that has come from AIMS, I think so. And this data does tell that the lower dose pazopanib, they found that little more toxicity was there compared to Western population. Then it's still a very retrospective data, is not of high quality, but that's the best I could find out. Last question. Any one of you remember last when you referred it for radiotherapy, any patient of RCC metastatic advanced?
Only brain mets or bone oligomet.
Leave the brain mets apart. Last patient, anyone had referred?
Yeah, hemostatic RT.
Bone
isolated bone mets, SBRT.
Pain agreed, brain mets agreed, hemostasis RT agreed. Apart from these indications, classical, anyone thought of anything else?
SBRT.
SBRT. Yeah, when was the last time you sent it advanced RCC for SBRT?
Rare, very rare.
Okay, so I find out some evidence, and this is something I don't advise this. That's very clear. There's a disclaimer. I don't want to advise, but let's see what it is. It's the data which I feel as a medical oncologist we keep our eyes shut, and we should look at this again at data which is the prospective somatocentric in a symptomatic patient. That is a very good response rate. If we're looking just at the responses, there's a beautiful responses that comes in with SBRTs. And what they wanted to conclude here is they wanted the NCCN to evaluate SBRT specifically in 2 or 3 conditions. That is the treatment of residual lesions in the kidney and treatment of previously inoperable RCC and adjuvant treatment for high risk. There's no data for that. High quality data is not there, but that is what it is all about. So to conclude, if you look at it, sunitinib has a response rates of around all risk 27%, but the highest response rate comes with the axitinib, pembrolizumab, and the EP and the nivo arm. These are the 45 to 55% of the response rates. We have seen an increase in PFS from 5.1 months to now at 15.1 months. And look at this data. We do find the interferon era is gone. It is only for a very select few. I don't feel any one of us does that now. We now know that TKI is already there. The combination of TKI-IO and the IO and IO is there to stay. I don't know what the future stands. But one thing is there. Look at this. For the 3-year survival from the interferon to where we have reached today to this part is a huge 3-year survival which is touching around 35, 40 to 50%. And that's what it is all about, RCC. So to answer that last question, to conclude, if you use a TKI, cabozantinib, sunitinib, pazopanib, you still can go for immunotherapy as a first-line choice. You can go for a TKI to a TKI, as Dr. Raja told, if the response is very good in the first line, you can just switch over to a TKI even a second line, means more than 1 year of a PFS. If there is a poor PFS, probably immunotherapy is a good choice for us. But if you use immunotherapy, still you can use TKI in the second line, and cabozantinib is a good choice. Lenvatinib, everolimus, although phase 2 data, there's good data to that. Axitinib, there's data post TKI to TKI. But most of us refrain from using TKI post TKI. So everolimus, I found one of our panelists very eager to use it, but the data is most of us agreed that although it can be given, should be not, if the response is not huge, and it has been shown to be inferior to majority of the combinations. So that is it, what I wanted to go through. And if there is anything which I have not spoken about or not done about, any of the panel wants to tell last few words, because we have 1 more minute left before this ends.
Sir,
About